Welcome in, everybody. I'm sorry, my voice is still getting over being sick, so if I sound a little off, that is why. But we are back after a couple weeks off due to said illness. Um, but thank you for the raid from Bree. Welcome in, everybody. And as always, we have our little trivia question at the beginning. So today's question, actually, it's kind of a two-part question, although one of the questions is more of just a thought, something to think about, but I don't have an answer for right here. So this week's question is: a core goal of the new 40-hour MD nutrition mandate is to better address the metabolic syndrome epidemic. However, when a patient consumes an excessive amount of refined carbohydrates, the body performs de novo lipogenesis, which is the generation of fat, to convert that glucose into fat. In humans, what is the primary anatomical site where this biochemical reaction occurs? And just for your own thought process, how do you think this differs between humans and other animals? So we have the answer choices are adipose tissue or fat cells, skeletal muscle, the liver, or the small intestine. So get your answer in the poll, and we will get back to this at the end of the show. But today we are talking about something that has recently happened where RFK Jr. has come out with these new education guidelines, which he says it's not a mandate. He said it is optional for medical schools to start offering, instead of 20 hours of nutrition curriculum, he is recommending that they start to offer 40 hours of nutrition curriculum. And you may be thinking, what is the problem with doctors having more information about nutrition? Well, I could debunk this whole like thought process. I mean, it's not that the act of learning nutrition itself isn't the problem here. It is the rhetoric behind this decision, it's the motive behind this decision, and the consequences of this decision and the other decisions kind of made in conjunction with this. So I could debunk all of this in just one argument, but that is not interesting enough for an hour and a half show. But they're claiming that nutrition education is the key to making America healthy again. Meanwhile, they are cutting financial aid funding for dietitian programs. So that alone should be convincing enough of an argument to say they don't actually mean what they're saying. They don't actually want nutrition education. They don't actually value it that much. But there are a few different arguments I want to kind of bring your attention to today. And a lot of that revolves around kind of these misguided ideas of what is medical school education, what is it meant to be, what are you actually going to retain from your medical school education, and also a big one is what is the role of a physician in this evolving healthcare industry and healthcare system in the United States. There are a lot of misunderstandings about what doctors should be, and there's a lot of doctors even who may disagree with me on my perspective. But we will kind of start small, and we will kind of get to that bigger point near the end. So, uh, yeah, and let Bree know if the redirect worked for everybody. It seems like a lot of people got over here. I'm seeing a lot of people in the viewers. Just I don't think a lot of people are as active today. But um, so I'm gonna play just actually I don't even need to play the clip because it just goes into talking about RFK Jr.'s guidance for nutrition education. So I do just want to cover, what nutrition do doctors learn in medical school? So the I say this a lot, but the medical education system is pretty long. So first of all, you have to get an undergraduate degree, and you have to get prerequisites in general chemistry, organic chemistry, general biology, biochemistry, et cetera, et cetera. You also need generally should have biostatistics, you should have calculus, you have to have physics, Now you have to have psychology, sociology as part of that as well. And then you, once you graduate from undergrad, which is a 4-year program, then you apply to medical school, and it's pretty competitive to get into medical school. But you either go to an MD school or a DO school for 4 years. The first 2 years of that are more school based didactic education. So, your typical lecture style, you're taking tests very frequently, you have anatomy lab, that's where your cadaver lab comes into play. And then all of that, a lot of people misunderstand what medical school teaches you, right? So, um, a lot of people think that you learn medicine in medical school, right? Like that just sounds intuitive. But really, let's there's a quote that I don't know who started saying this, but it makes a lot of sense. So undergraduate or pre-med teaches you how to study. It prepares you for the workload, and I don't think it prepares you all that well for the workload of medical school, but that's the goal of undergrad, is to prove to medical schools that I am not an academic risk. I can pass the boards, I can pass this degree program, and I will very likely be successful in this academic program. And then in medical school, you learn how to study medicine. You don't learn how to be a good doctor in medical school. You learn the foundations to set you up for residency training. And residency is where you learn how to be a physician. So when they're trying to make all of these reforms for expanding things that you need to learn in medical school, I have a few questions. Namely, like, you are drinking through a fire hose in medical school. And there, I remember in my education, I had 2 exams every single week, except for finals week where we had five. And each one was 15 hours of material on slides with font literally this big. And if I didn't study for 16 hours every day, including weekends and vacation, I was behind and I was worried I was going to fail. And there were times when I was even taking material into finals week that I had not touched because there was so much to cover. And so my question is, adding an extra 40 hours of nutrition education, how much of that is going to be retained by medical students, knowing that you're learning so much, and the material that you're going to actually focus on is not the whole of what's being taught, right? You learn all of that stuff to pass the test in the class, but really what most people are spending their time on is board preparation. So material that is not going to end up on your USMLE or your COMLEX boards, people aren't really going to focus on, because that's not going to set you up for a career in medicine. You have to do well on your boards to get a residency position. So something that we really need to think about is, when we add material, what are we giving up? Humans only have a certain amount of brain space that we can utilize for education. And no matter how hard you try, you cannot learn beyond a certain capacity, and you can't study beyond a certain time limit. So medical school becomes a gamble of how much gain am I going to get from extra study time. Like, if I dedicate an extra 4 hours to studying and I only gain 2%, a 2% increase in my test score, is it really worth it to sacrifice more sleep? Is it really worth it to focus on low yield material compared to high yield board prep material? And then understand that your knowledge base is going to refine and grow as you get into your clinical years of medical school and into residency training. So even though it seems like a good idea to add more education on nutrition. Even if you add it, I don't think that the extra material is going to add much benefit for medical students, especially those that are early on and don't know how to apply this information yet. Another factor of this is what is actually going to make a big difference in nutrition, in global nutrition, in United States nutrition. And we've covered this on many episodes of Medical Myths. The fact that the systemic issues are primarily the cause for a lot of these lifestyle related illnesses. Like we're talking cardiovascular risk, we're talking diabetes risk, those things that are preventable through lifestyle means oftentimes come with a premium price. And what med schools have been doing instead of just tacking on extra nutrition education that people aren't going to utilize, what they've been trying to do more is adding um is adding more humanity in medicine. Like, and I actually took a class called Humanity in Medicine, adding more knowledge on socioeconomic factors, on social determinants of health. So, what zip code are you in actually determines your risk for a lot of chronic disease. And so, how about we address some of those things that we can actually do something about? Physicians are in a position to be able to help with that. We can be political advocates. We can uh, think of ways to better decrease food costs, advocate for improving food deserts, advocate for uh, child care, free education. Those kind of things are going to do leaps and bounds more than a doctor learning some extra information that they're not going to remember in the first place. So that is one part of this argument. Um, and another part of this as well is this idea that physicians don't learn nutrition, which they don't in a whole lot of depth. And there's a lot of reason for that. So the role of a physician is to diagnose and treat certain diseases. And there are many diseases to remember and remember management for. And we do like the nutrition that we learn is often in conjunction with other topics. So an argument that chiropractic will use a lot in promoting their field is to have a graph that says on this side, these are how many hours that chiropractic students spend learning anatomy, physiology, diagnosis, which like how much do chiropractors really diagnose? Not much. But they'll list out the subject titles and how many hours that chiropractors have in that particular class. And then they'll put, oh, well, MDs and DOs have less education than chiropractors on anatomy because they only take this many hours. And so there is actually a big skew in how they're presenting this information because the class titles in medicine are different. And especially now they're different because a lot of schools have shifted from a traditional model into a systems based model. So, the traditional model of medical education is that in your didactic years, you have separate classes, like similar to many university programs where you have a certain class for anatomy, you have a set class for physiology, a set class for biochemistry, et cetera, et cetera. But now the systems based model has different blocks of time. So, like, you spend a month on the cardiovascular system, and in that point, you learn all of the anatomy, physiology, pharmacology, pathophysiology, etc., for the cardiovascular system. Then you take a test on that, and then you move on to the neurologic system, etc. And so that way, yeah, your class title isn't nutrition. Your class title isn't anatomy. The class title, like all of the classes, are under the same umbrella as cardiovascular system, but you have the professors from those departments all teaching on that subject matter at the same time. So when I went through medical school, the way that nutrition was taught was actually predominantly lumped in. Well, it's lumped in a few different places, but the more microscopic side of nutrition, like the more nuts and bolts kind of mechanisms of nutrition, were covered in biochemistry. And I remember we did have a nutrition unit, if you will. Um, but that was really is talking about macronutrients, micronutrients, and because biochemistry is where you learn all of these metabolic processes. So that's where you're learning about glycolysis, the citric acid cycle. You're learning about the urea cycle, how nitrogen is utilized in the body. You're learning about how fat is utilized and generated in the body. You're learning about cholesterol management, how you dispose of cholesterol. All of those things are done in biochemistry class. So it's easy to say, well, you're not taking a set nutrition class. Well, no, I'm not. But that material that is relevant to a physician level of education is done as a biochemistry class. For example, there is let's talk about vitamin B, specifically vitamin B12, and I believe B9. I get the numbers mixed up sometimes, but folic acid and vitamin B12 are very, very important B vitamins, and they're very important neurologically. So when you have an absence of vitamin B12 or folate, you can actually get numbness and tingling throughout your hands and your feet and other parts of your body because uh, you're actually regulating your homocysteine production and waste with vitamin B12 and folate being cofactors for that specific chemical reaction. So if you understand the biochemistry of vitamins and their function as cofactors, you know you can logic your way through what happens when you don't have that particular nutrient available. And then kind of with that, you have your classes on pathology and also classes on introduction to clinical medicine, where you start learning about disease processes and you learn about how to test for certain conditions, what are signs and symptoms of different conditions, and how do you manage them. And so then you see that same material coming back up. And so when you talk about things like malnutrition and like certain types of like protein deficient malnutrition, we can evaluate those particular conditions and understand the underlying process that makes you have the symptoms you do. Like, for example, in a lot of third world countries, if you have uh, a lot of access to carbohydrates, so we're talking countries that have abundant rice production or abundant grain production, but meat is very expensive or a luxury product. People don't have access to high protein items. And so they end up eating a lot of rice or a lot of wheat. And then if you only have rice and or wheat without protein, you can become like your belly actually becomes very distended. And so it looks like you're super skinny in your extremities, but your abdomen is very bloated, and that's a symptom of protein deficient malnutrition. Um, so there are examples like that where we are learning a good bit of nutrition and something else. And this is something like going directly against RFK Jr.'s argument that uh, like just his whole approach to food is medicine is that if the more doctors learn about nutrition, the more they'd actually learn how wrong RFK Jr. is because his whole claim is that um, chronic disease prevention can be done with lifestyle measures, which there's a big issue with that. I mean, there are chronic diseases that have lifestyle risk factors, like I mentioned, but there are also a lot of chronic diseases that don't. For example, a lot of autoimmune disease have nothing related to uh, like dietary factors. A lot of Infectious diseases have more to do with your proximity to at-risk people or being in an at-risk geographic location. Will like having chronic effects of um, trying to think of a good one, like Chagas disease can cause early onset cardiomyopathy. And often you're going to see that in people coming from South America because of where the bugs are that transmit that particular disease. So feeding somebody a salad instead of a burger isn't going to prevent chronic symptoms from Chagas disease. That is absolutely ridiculous. But thinking about cardiovascular disease, this is a great one to think about because what do we know? And this is something that physicians are very well taught in med school and in primary care focused residencies. You learn about risk factors for heart attacks and strokes, and one of those is high saturated fat intake and high red meat intake. So actually, the nutrition recommendations for prevention of heart disease and high blood pressure and diabetes is a Mediterranean diet, which is a low red meat, more like fish, chicken as like a small portion of your diet, and the rest of it being plant oils, vegetables, etc. So that is directly anti his carnivore stance, and the other one being whole food plant based, which again kind of goes against this idea that you should be eating steak for every single meal, and that's somehow going to prevent your chronic disease. So, ironically, I think that this measure of an extra amount of nutrition education for medical doctors will actually allow them to contradict his viewpoint a bit better. So that's just something funny that I noticed about all of this. Um, but if we think about like how I was talking about medical education, where we really learn about the things we need for our future practice, it's in residency. And the reason for that is we're going to get into a little bit of economics actually in today's lecture because let's think about this real quick. So we if we're going to be in an economically healthy society, there are a couple things that improve economic health, and one of these is division of labor, specialization. So division of labor leads to specialization, and this is kind of where we're going to get into for the rest of the show today, and highlighting how division of labor has changed in the healthcare industry and why it is so important, especially today. So, who does what job, and the fact that if you specialize in a particular field, everyone is going to do better because everything comes down to opportunity costs and trade-offs. Like I was saying with studying for a test, is it really worth it to be sleep deprived and study an extra 4 hours for a test when you're only going to maybe earn an extra 2% on that test? It's not really worth it. What other things could I be doing with that time? I could be advocating for human rights. I could be sleeping. I could be uh, doing something to make me not hate my life as a medical student. I could be exercising. I could be caring about my own health and well being, right? So, what are the trade offs? When we add this extra thing, what are we giving up? And in a society where there are so many more people now compared to medicine in the 1950s, and this goes for any job, not just medicine. Um, the fact is, we've had to become more efficient and more cost effective in producing one specific thing. So even if you are able to do multiple tasks at the same time and sell that skill, um, it will actually be better for the economy and for the population in general if you focus on one thing, because you're going to do that one thing better. You're going to end up innovating in that particular field instead of dividing your attention between multiple things. And so when we say the opportunity cost, it's like it works this way as well for medical specialties. If I choose to pursue education in primary care, I'm giving up my ability to specialize in something else. Granted, they are going to have a lot of breadth in their practice, but they're going to sacrifice depth. And this is where medicine has had to expand into a team based effort. And we're going to pull up an article here in a second. Kind of, actually, we're gonna look at a few different arguments, and I'll kind of give my thoughts. A lot of them are relate to the things I've already mentioned thus far. But RFK Jr. and this whole administration has their heads stuck in the 1950s. And even you could argue the 1940s because they really want us to be in World War II again. Um, but they are imagining the role of a doctor as it was in the 1950s, where we have this idea that physicians are the end all be all. Physicians are the person in control of your health. They are the ones leading you and guiding you to be the best person you can be. And they're going to come to your house. They're going to also be at the hospital. They're also going to deliver your babies and they're going to do surgery and they're going to be your nutrition counselor and they're going to like you can want to be all these things, but realistically, how much can you actually do? And is that outdated thinking problematic for patients? And I would argue, yes. Yes, it absolutely is. And I think that uh, this rhetoric is harmful to patients. It's also harmful to doctors, and it stems from it stems from RFK Jr.'s just misunderstanding of what doctors are and what doctors should be, a misunderstanding from his perspective on what chronic disease is, and the complexities that go into learning about chronic disease and managing chronic disease. But it also falls on doctors. And I think largely on older generations of doctors who believed they were the lone wolf in medicine, who have a case of um, like main character syndrome. And I think this is where we have to think, what is my role? How do I make the whole team work better? And a lot of that's going to come down to doctors not taking credit for everything. And that's going to hurt some egos, but good. I hope it does because we don't need any more ego in medicine, especially not right now. So I'm actually gonna pull up. Uh, I'm gonna pull up an article here first, and I actually have from the same website. I have two contradictory articles from medical students about their thoughts on this whole nutrition situation. So let's first look at this one that I actually saw the uh, is either the White House or the HHS had uh, reposted this, and so I had to look into this one. But I guess disclaimer: I cannot read the whole article because it is behind a paywall, and I'm not going to pay for this. But the title says, "I'm a medical student. RFK Jr. is right about medical school and preventive care. I'm in my final year, and I've learned little about how to prevent chronic disease." And this gives me a little bit of a flashback to our episode on Casey Means and why she is incapable of being Surgeon General. And because she made a very blunt and bold statement saying that Stanford did not teach her literally anything about medicine. And I'm going to say right now, I don't know who this medical student is, but this med student should not be a physician. This level of ego that I am seeing from this medical student makes them I think it's going to make them a very dangerous doctor. So let's get into what this person is saying. So, I mean, they emphasize that I'm in my final year and I've learned little about how to prevent chronic disease. Okay. Yeah. And the only I guess this is a she. My apologies for misgendering this author. Um, so the little bit that we can read says the first patient I met as a medical student was a middle-aged delivery man and a former track athlete. He was recovering from his second amputation due to uncontrolled type 2 diabetes. When he told me he never realized how much his high sugars could cost him, I wasn't sure what to say. I rotated at four busy New York City hospitals during my medical education. Each day, I saw patients with similar stories, people living with the consequences of poorly controlled chronic disease. I learned to assess for strokes, manage heart failure exacerbations, and explain the vascular impact of diabetes in fancy physiologic terms. I learned to treat the complications of chronic disease well, but I learned little of how to prevent them. I am now a fourth year medical student pursuing a career in internal medicine with a focus on chronic disease prevention. I entered medical school eager to learn how I could shape my patients' health through nutrition, lifestyle, and preventive medicine. And I'm guessing they go further to expand on why their medical school failed them. And like I mentioned, the hubris of this medical student to think that medical school is the epitome of their education and that they can't learn any more than, what they've learned thus far as a fourth year medical student. And like what makes this even more funny to me. Um, so when you're in medical school, you have to do a certain amount of a variety of different rotations. And most of them you're spending really only 1 month doing them, maybe two. A lot of schools make you do like 2 months of internal medicine, 2 months of family medicine. But then every other rotation gets about 4 weeks, like 4 to 6 weeks, unless it is a specialty that you are actually trying to go into, in which case you do extra rotations to try to audition for those residency programs. So med students, like, you are learning the very, very basics of what that specialty is like to work in, and the very, very basics of like textbook disease management. And so to see this fourth year medical student say, yeah, well, I learned all these fancy things, which you learned the very basics. Like to say that you learned how to manage heart failure exacerbations, I'm going to argue this person learned a little bit about heart failure exacerbations, but like I haven't even completed my residency yet, and I can manage some heart failure exacerbations, and definitely I cannot do it without an attending and without a cardiology consult. Uh, but like I can prescribe GDMT, which is kind of the recommended like maintenance therapy for heart failure. I can prescribe diuretics. I know how to assess diuresis and all that. But those are skills also that I learned in residency and not in not in medical school. Like I think a lot of medical school is learning how to present a case to an attending, how to it's again like med school is how to learn how to study medicine. And so you build up those study techniques and then you go to residency with that foundation and you expand more. And somebody from the side chat saying if they learn enough to place blame somewhere, they obviously learned something new. The blame part is weird to me. Yeah. Yeah. And the fact that they're saying that they learned things. You learned how to assess for strokes. You learn how to manage heart failure exacerbations. You learn about the vascular impact of diabetes and the fact that you were a med student and you were able to have a conversation with somebody with uncontrolled type 2 diabetes. You obviously learned some things about that, which is great. I don't know why you're saying now that you didn't learn anything because you didn't learn the specific things that you wanted to learn right off the bat. So I think this is a lot of hubris from this fourth year medical student. And Something else is a lot of the depth of these specialties you're not going to get into as a med student because most med students aren't going to go into the same specialty, right? Like an anesthesiologist, like someone going into an anesthesia residency, doesn't really need to have these big nutrition conversations with people because that's not their role. Their role is in the OR or doing pain management. Like they are proceduralists. Same thing with um, like orthopedic surgeons. Why does an orthopedic surgeon need to, or someone going into orthopedic surgery, why does that person need to have the ability to function like a dietitian when they're going to be in the OR doing bone procedures and muscle procedures? That is a poor use of education, a poor use of resources for something that you're going to develop later. And a lot of nutrition counseling, like where I learned about Mediterranean diets and learned about plant-based diets and how to talk with patients about that, was in a family medicine internship. So something else, if you want to go into internal medicine with a focus on lifestyle medicine, guess what? Like you'll be in for a surprise when I tell you there is a fellowship now. Like there are fellowship tracks for family medicine and internal medicine dedicated to lifestyle medicine and helping people learn how to do those things. So, and this is something that I see with a lot of medical students and a lot of pre-meds is this idea that I want to do the end goal today. I want to do the end goal right here, right now, because I want to fulfill my dream and I want to save people's lives. And like, it's great. It's great to want to help people. But this main character syndrome is kind of out of control with people. Like, you don't need to necessarily be the one to do this. Like, why can't the dietitian help people with this? Why can't the dietitian uh be a lifesaver? Why can't I couldn't see myself on the bottom of the screen. But like, why can't somebody else do that part for you? Or why can't you wait to get those skills and then do it as a qualified attending physician? So just wait, just give it a year. At least finish your internship. You'll be surprised about what you learn about heart disease prevention, diabetes prevention as a resident, and you're going to learn more than you ever would in medical school. Yeah, and the fact that you have to recertify, you have to stay up to date on these things. You're going to keep learning through medical journals and through conferences. Like the education doesn't stop here. And I think it's flawed to think that you're just going to walk out of medical school knowing everything you need to know. So let's go to the flip side, to this other medical student. And this is from the same website. And all these are opinion articles, of course, but this one is called "What RFK Jr. Gets Wrong About Medical School and Nutrition Education." Instead of focusing on future doctors like me, expand access to registered dietitians. Absolutely. And again, if your goal is to improve nutrition and access to nutrition education, why are we cutting financial aid for dietitian programs? Why? There's a whole group of people, a whole group of degree fields that are largely um like predominantly women, and I think that's part of why they got defunded essentially. But they got told that they are no longer considered professionals in terms of financial aid. So nurses, occupational therapists, speech therapists, uh, dietitians, they are all restricted in how much money they can take out to go to school. And so we're going to see a lot fewer people entering those programs. There are programs that are going to close down probably, especially those that aren't part of some big prestigious university. And so this idea that doctors and future doctors have to then adopt the role of a dietitian is insulting to dietitians. It's insulting to doctors because you're asking them to know things that's not part of their scope of practice, and you're taking away their time to actually study their own field, and you're not listening to them about the things that they need to focus on. So that's like the biggest point out of all of this. But this person goes into the vitamin B12 conversation that we recently hit on. And they say, during my third year neurology rotation, I had several elderly patients present to the clinic with concerns about pins and needle sensations affecting their mobility. Each time these patients came, my resident physician would ask me what labs we should request. Checking their vitamin B12 level was high on the list. Vitamin B12 deficiency is one of the most common causes of peripheral neuropathy, particularly in elderly patients, which affects their balance and ability to walk. This is a nutritional fact I and almost every medical student in America learned in preclinical nutrition courses. One of Health Secretary RFK Jr.'s refrains has been that doctors don't learn enough about nutrition in medical school. In a recent op ed in the Wall Street Journal, he called for rigorous, measurable nutrition education at every stage of medical training. Contrary to what Kennedy might have you believe, medical schools do teach students about nutrition, and I'm going to zoom in even more. Do teach students about nutrition. However, most of our nutritional education centers on dietary deficiencies that have life-threatening and potentially irreversible consequences. Absolutely. These frequently require medical intervention, which requires a prescription or can only be administered in inpatient settings by a healthcare professional. For example, a patient with subacute combined degeneration, a severe neurologic condition that comes from prolonged B12 deficiency, will need a prescription for an intramuscular B12 shot. We also learn about how vitamin K deficiencies can lead to bleeding disorders in newborns, which, again, okay, vitamin K is part of nutrition. And so, like, I think people have this idea that nutrition is just related to eating salad. Like, I think a lot of people just think of salads and think of protein shakes when they think about nutrition. But all nutrients are really tied to this discussion of nutrition. And a lot of the people in RFK Jr.'s camp are opposed to vitamin K shots at birth, which kind of is counterintuitive to this idea that nutrition should be prioritized because vitamin K deficiencies are a nutritional illness. Um, how much is the curriculum standardized across medical schools, if it is at all? It's fairly standardized. There's some variability in terms of, like, my school required a cardiology rotation in third year, where many schools will say that that's not a requirement, that's an elective, while others will say you need a neurology rotation instead. And so, like, some of that is variable, but all of the schools teach to the board exams, and the board exams are extremely standardized. And also the exams at the end of clinical rotations are completely standardized. So uh, the education is, like, with that regard, fairly standardized, uh, with, like, very minor differences in how they teach. Um, Yeah, so they cover that, and, yeah, vitamin B9, which is folate, and B12 deficiencies can cause anemia. That's another thing. Those can lead to macrocytic anemias, and protein deficiencies can lead to kwashiorkor, which is what I mentioned before, where you have high carb, low protein diets, um, which is a cause of death for children in third world countries. So yeah, and something else I want to mention is things like sodium, water, potassium, magnesium, phosphorus. Those are all very highly tied to nutrition, and that I'm wearing my kidney shirt, but I'm in training. Well, I'm about to be starting training to be a nephrologist. And if there's one thing, like, I'm going to do a whole video at some point outlining why I chose nephrology and what are all the things that nephrologists do. But one of the big things is electrolyte disorders. Like if you have concerning electrolyte issues, nephrology manages that because those electrolytes are regulated through the kidneys. So your lab numbers of your sodium is actually a reflection of how hydrated you are. Potassium levels are important. Having low potassium or high potassium can lead to cardiac arrhythmias and cause death. You can have issues with phosphorus that lead to uh, bone breakdown, like osteoporosis. So we do focus on those things, and I think certain specialists really do. And like I haven't even mentioned GI specialists, right? Like let's talk about gastrointestinal specialists. Like they do a lot of nutrition counseling and a lot of nutrition training because they study gut health and absorption of nutrients, and they do a lot of really in-depth workups of why is somebody not digesting properly, and it's really fascinating. Something else, endocrinology. Like if we're talking diabetes experts, endocrinology, really, really good for that. And something else here, and that I'll get into in a later article, is this team-based effort within all these specialties. Like one of the most influential people other than dietitians for uncontrolled diabetes are nurse educators. Like learning about, like, so doctors only have a set amount of time for each patient. And that allows them to be, very, very efficient, but it also creates the need for other team members. And there are people who are incredibly skilled at talking with patients and like that very social side of medicine. And guess what? Nurses, nurses are trained very, very well in that regard. So why are we going to rely on somebody with very little time, very high burnout, that maybe has more of the academic skills, but not as many of the social skills? Why do they need to be the nutrition educator and not a licensed nurse educator? And I learned from some of these people in medical school on an endocrinology rotation where like they have the time, like they spend a half hour to an hour sitting there with the patient talking about, okay, here are your blood sugar levels. Here's how you can reduce your A1C. Here's how you use your insulin. Here's how you take your meds, like spacing them out or taking them with food or whatever. Here's how you can get more exercise. Here's how you can improve your nutrition. And then of course they also see a dietitian, but why are we not valuing nurse educators that much? Like, and again, nurses are on that list of no longer considered professionals, and they're losing funding as well. So we can make way better use of our people, and I think that's how we need to approach this. Yeah, so they go on saying, however, adding a few nutrition classes to the medical school curriculum is unlikely to produce widespread improvement of America's nutrition on a broader scale. To truly improve nutrition education, access, and application for the average American, the Department of Health and Human Services should focus on increasing educational opportunities for registered dietitians. Yes, 100%. Improving access to evidence based nutritional experts. Yes. And encouraging medical schools to offer interprofessional education. Yes. 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 This. And actually, I had in my medical school, I did have a class about interprofessional development where we met with students from other uh, healthcare fields at the same school. Like we had a dentist in our group, or a dental student, an occupational therapy student, a physical therapy student, a PA student, myself. What else do we have? Like they have a cardiovascular perfusion program. Like so, you have podiatry. you have all these different professionals, and we had a problem we needed to solve, or like we had to think about how can we improve healthcare outcomes all working together. And that's exactly what healthcare needs to be in this country. And people are going to have much better outcomes. Our system is going to go much farther if we do that. And I understand that there are concerns from patients maybe saying, I don't have a lot of money, and I would much rather go to a one-stop shop to get all of this taken care of instead of going to multiple specialists or multiple different healthcare professionals. But if you're getting a referral to somebody else, it's I think it's one of the most honest, other than like if it's something that you should be able to do yourself, then maybe you need to consider getting some extra training. But like a referral isn't them just turfing you to somebody else. At least most of the time it isn't. It can be one of the most honest things that people do. It's saying that my my knowledge ends here, and we need to call in somebody else who does this more than I do. And I think that is the best way to keep people up to date on the skills that they need to know, and it gets patients the best level of care because they get to have multiple opinions. And I think having more people working together is is the best way forward. And the fuzzy logic makes a really great point here. I suspect that there may be motivation to devalue RDs so that unregulated nutritionists can fill the space left behind. Yeah, that is a big issue as well. You're leaving space for grifters to take those slots. You're leaving space for functional medicine, which isn't a real thing. Um, these holistic practitioners, which, like, yeah, medicine itself is moving into a more holistic model, but that's because we've learned more about how affecting all of these things improves your health on the whole. And actually, I was watching a lecture earlier today, mentioning that, like, it's not like going to a chiropractor isn't a more holistic option. Going to a DO versus an MD isn't choosing a more holistic option. You're the people who are more holistic generally are the people that went to med school more recently. It's more based on generational teaching, and how we're trained to be more team based now than we were in the 1950s. So that's definitely a big consideration. Yeah, and this is hinting on the next place that we're going with this. Kennedy's impulse to start with medical student nutritional education underscores an unhelpful myth that medical doctors should be leaders in all parts of a person's health. Registered dietitians spend 2 years intensely studying and completing more than 1,000 hours of clinical work in the field of nutrition. They are not medical doctors. Not medical doctors, should be respected as the primary healthcare for providers for patients who would like to improve their nutrition. Absolutely. I co-sign this. Yeah, and if even if medical schools bolster their nutritional courses, they simply cannot offer a nutritional education that rivals that of RDs, nor should they. Instead of pressuring medical schools to change their curriculum, Kennedy should focus on helping more people become registered dietitians and giving patients more access to their expertise. Yeah, why do people like Kennedy overlook the value of registered dietitians? I can't help but notice that women account for approximately 94% of that field. Yeah, and so they hit on this very well, and I mentioned a lot of this earlier, so I'm not gonna kind of go into that. But they give a great example here, which I also hit on recently as well. That for people with type 2 diabetes, a lot of them also have chronic kidney disease, and when you eat protein, protein is broken down into amino acids and waste products, which are filtered out by the kidneys. So you have to be cautious. And actually, like when we're talking about nutrition education, this is something that I didn't know to the extent that I'm going to learn, but uh, nephrologists do a lot of nutrition guidance as far as what electrolytes and like what minerals do certain foods have in abundance that are harmful for people on dialysis. Like they have people watching out for their potassium intake and their phosphorus intake because it actually can kill people who are on dialysis. So having some of these more general healthcare recommendations, um, and being misinformed on some of these nuances can be very, very harmful. And so it's important to not get Dunning Krugered about thinking that nutrition is just so intuitive, or that you just need to eat steak and that'll cure all your chronic disease or prevent all your chronic disease. That's not always a good approach, and that can really, really be harmful. And and yeah, the people who are going to know that, who are going to know how to work through those nuances, uh, are dietitians. And something else I want to hit on too: dietitians in the hospital setting, especially pediatric dietitians. Oh my god, they are some brilliant, brilliant human beings. Like people who really know the ins and outs of certain types of formula. Because babies in the hospital, like a lot of times their parents aren't there to take care of them, aren't there to breastfeed them if that's what they were doing. A lot of kids have to go on formula when they're in inpatient settings. Um, and there's a lot of tweaking with, how much do they need? How much formula do they need in a day? What specific nutrients do they need in this formula for their particular age group and their healthcare considerations? Like, there's a lot that goes into this, and having dietitians available, for you to consult and learn from is like, no physician can take over that role except maybe, like, peds GI maybe, but even, like, peds GI is focusing more on the pathology, not as much on the day-to-day nutritional maintenance of these kids. Yeah, and they talk about interdisciplinary education. And they talk about, yeah, so that medical school isn't the end all be all for um, med ed. All right, so this last article that I want to get into is about. This is an older article too, but this is about the myth of the lone physician toward a collaborative alternative, and it was published in the Annals of Family Medicine, the Annals, not the Annals. I know we got some dirty people in the side chat. From March of 2012. So older, but this highlights kind of the changes in how doctors are trained, what the expectations are for doctors, and just the reality of the system that we live in. So their abstract says cultural values and beliefs about the primary care physician bolster the myth of the lone physician, the competent professional who is esteemed by colleagues and patients for his or her willingness to sacrifice self, accept complete responsibility for care, maintain continuity and accessibility, and assume the role of lone decision maker in clinical care. Yet the reality of current primary care models is often fragmented. Interpersonal care for patients in isolation and burnout for many primary care physicians. An alternative to the mythical lone physician would require a paradigm shift that places the primary care physician within the context of a highly functioning healthcare team. This new mythology, I find the word mythology is a bit weird. Maybe methodology would be better. Fulfills the collaborative, interprofessional, patient centered needs of the new models of care and might help to ensure that the work of the primary care physicians remains compassionate, gratifying, and meaningful. And so, like I mentioned, healthcare is an absolute team sport. And um, we're going to get into here as well this kind of the dark side of medicine, and that is burnout, it's depression, it's compassion fatigue, and ultimately it's high risk um, of physician suicide. Like it is a very, very challenging field, and a lot of people go into the field wanting to be the hero. They want to save the day. They want to be the person responsible. And then the reality hits you about how much work is involved in that, how much responsibility is involved in that. And when you don't know the answer, sometimes you have to make a decision, and those decisions weigh on you incredibly. When you hurt people, that weighs on you. And the burden that we're placing on physicians is leading them to quit medicine in large numbers. It's leading to physician suicides. And it's creating a bigger disparity in meeting healthcare needs across the country and even around the world. And so we need to think about what like what is an appropriate role for physicians? How do we maintain that work life balance? How do we maintain a healthy level of responsibility and self compassion and forgiveness for when things don't go well? And the fact that RFK Jr. is putting that burden, more burden, on future physicians who are already incredible idealists a lot of the time. Um, and so, like we saw with that fourth year medical student saying that I went into medicine to be the one to help people with their chronic disease. Yeah, you can hear Henry in the background. Um, but yeah, I want to be the one to do this. And and this is actually kind of related to my own story and my own transition from family medicine to nephrology is that I went into medicine to be an advocate, and I had very high standards for myself. And even during COVID, I felt really bad. I felt so bad that I was in medical school while my bosses and future colleagues were out there on the front lines in the hospital. And I thought to myself, I should be out there with them. I should be helping, even though I didn't have the skills at that time. And throwing me out there would have increased the risk to me and also probably would have delayed uh, care for them. Like it would have just slowed up the system because having med students out there often slows the process down. But I had this ideal of the physician I wanted to be. And getting into family medicine, I wanted to be an advocate for trans people. And I'm still an advocate for trans people. However, not having that separation and having the responsibility of being the representation for trans people in medicine and feeling like that was on my shoulders to do and doing that as someone in the army as well, and having trans people like need extra things from me, and so advocating and being that person at work and being that person at home, it took so much out of me that I had like a pretty bad mental health crisis. And it's something that we need to talk about, like, why are we doing what we're doing? And is this the right role for me to have, or is this something that I can pass on to somebody else? Like, is somebody else a better person for this? And I learned that I needed separation. I needed my trans advocacy to be in my personal time because I wanted to still be passionate about it. I wanted to be able to put my full effort uh, into that when I had the ability to, instead of feeling like it was my obligation to constantly be that person. And that was very hard for me to say, I'm not the main character right now. I'm not the person for this role. And that is okay. And that's what we need more people like that. And we're saying now, this is a team effort. I'm going to handle my part. And you know what? I can still advocate for trans people in medicine. I can do it from nephrology. I will probably take care of trans people as a nephrologist, not necessarily giving them HRT or giving them surgery. But you know what? I can manage their dialysis. I can manage them in the hospital when they have an electrolyte crisis. I can help when they have uh, a severe respiratory issue that's throwing off their acid base balance, and somebody needs to manage the metabolic side. Like, I can still help in a different capacity. And I think that's a much healthier way to look at the system. Um, and so I think that's where a lot of this damage is coming in to the healthcare field. And and with this idea of the lone physician, it's also devaluing other people. Um, and they're gonna get into this. I'm not gonna waste all of my effort right now, but uh, we haven't even addressed this yet. But they say the traditional image of the primary doctor is that of the lone physician, black bag in hand, braving the elements to deliver a baby, tending to a feverish child, or attending the bedside vigil of a family's dying loved one. Whether driving on a rainy rural road in the middle of the night or treating a waiting room full of patients in an office, this lone physician has acquired mythic proportions in American society. Grounded in Greek mythology, this iconic lone physician embodies the noble ideals of superior knowledge, self-sacrifice, compassion, accessibility, ethical judgment, and equal treatment for all. This myth has persisted because it represents values and beliefs that have benefited both physicians and patients and is reinforced by our biomedical paradigm, social expectations of healing, healthcare funding, and legal culpability for malpractice. For individuals who choose medicine as a career, the myth promises physicians a sense of control over one's practice, over one's schedule, and over one's patient care decisions. The lone physician maintains individual responsibility and accountability, fostering pride in work that can span from making split second, life saving decisions to applying clinical acumen in discovering the accurate diagnosis for a complex patient. The subsequent praise and gratitude from patients and families nourish the physician and reinforce the notion of individual heroism. This sense of control, illusory as it may be, often overshadows our awareness of this myth's dark side. In this essay, we review how this myth clashes with the current reality of primary care practice and suggest an alternative that places physician within the context of a highly functioning healthcare team. So going on with this, and I know I'm reading a lot, but they just list this out so well. Day-to-day life for primary care physicians steers far from the idyllic image. The lone primary care physician would take an estimated 21.7 hours per day to provide all the recommended acute, chronic, and preventative care for a standard panel of patients. In a recent survey of general internists and family physicians, 78 reported little control over their work, 27 reported serious job satisfaction, and 30% plan to leave their practice within 2 years. And these are stats from prior to 2012. So I can only imagine these stats are worse today. For primary care physicians who embrace the biopsychosocial model, the myth fundamentally fails them as they strive to be super doc, one person to attend to the biomedical, individual, and interpersonal needs of patients and families in 15-minute increments. The tyranny of the urgent creates a work life in which autonomy gives way to isolation, continuity to fragmentation, and compassion to burnout. The reality of primary care work life and the perception that it is too demanding and stressful have discouraged student and resident interest in primary care careers. Only 10% of US medical graduates in 2011 chose adult primary care residencies, and the number of family medicine residency positions filled by US medical school graduates hovers at 50%. Yeah, and so there's a lot that goes into this. There's like when it's really nice to think that you are the person that handles every single one of a patient's issues. And this has gotten really out of hand, especially with the advent of being able to message your doctor directly. So in my family medicine internship, you had 3 days to respond to messages that you got. And that would be from people asking for prescriptions, people asking for referrals, people asking for appointments, people asking random questions, and you had to answer them. You had to respond. And so you already have a full volume of clinic. And in residency, you've got your clinic, you've got inpatient, you've got a variety of different rotations. Like you might be on nights and people are still messaging you at different times of the day, and you have to take time to respond to them. And so this idea that primary care is being able to work a 9 to 5 and then go home is not the reality that we live in. We have people who, well, now you have the ability to take your documentation home with you because you need all of that time to catch up on your notes, to do an adequate job for doing individual care for every single person when you only had 15 minutes with them in the office. And then you got them also messaging you in the off hours. So there's pretty much zero work-life balance in primary care. And that is contributing more to burnout. And this is why doctors, you should just not give do not give your patients your phone number. And as much as like I want to be accessible to everybody, I can't. I cannot just respond to everybody's medical questions all the time. Um, and so that definitely contributes to burnout and leads to jaded physicians. It leads to physicians treating people wrongly. It leads to people leaving medicine and leads to them uh, opening up, like med spas and just focusing on making money instead of providing the care that they went into medicine to do. So, yeah, so they get into this high functioning healthcare team, which I've mentioned kind of, and it's this idea that, and I actually might be able to pull up a diagram about this. Let me see. Care team. Yeah, it says team-based care roles. Uh, I mean, oh, Godless Granny, thank you so much for the $20 super chat. Robin's surgery went well. Thank you for your help. Yeah, I'm so glad Robin was able to get that very important medical care, and I'm happy that my advice kind of led to that discussion. So I'm so thrilled to hear about all that. Where is it? Specialty. It's not showing me one of them. At least not the one that I'm thinking of. Okay, well, I can just describe it the best that I can. Actually, this slide. No, I don't want to open the video. Okay. I can't find it. But either way, so imagine, if you will, a wheel, like a bike wheel or a wagon wheel or something, where you have the center of the wheel is kind of like is your primary care physician, your primary care provider. Not going to exclude NPs and PAs in this because they're a very key important part of this too. So you have your primary care provider in the middle, and they're your entry into the medical system. But they're going to do their piece. And then if you think of the spokes of the wheel being different medical specialties or even different healthcare professionals. So you've got nephrology's on there, cardiology's on there, you've got dietitians, you've got therapists, you've got all kinds of therapists, mental health therapists, occupational therapists, speech therapists, you've got nurse educators. All of those people are on different spokes on the wheel. And the primary care job essentially is to determine which of these places, if any, the patient needs to go to. And then the primary care provider is like, their role is essentially to coordinate the combined efforts of everybody on the team. So like it's a very, very important role. However, it is not them managing every single issue on their own. It's getting the help where they need it and kind of handling it from there. So if cardiology gives recommendations for a heart failure patient, like, hey, this person was in the hospital recently, they're having worsening heart failure. Here's what we did in the hospital. We're going to see them again in, I don't know, a month and then maybe 6 months after that. Uh, Here's what we recommend you do from here. And then primary care says, okay, awesome. Thank you for those recommendations. We will keep working on it because, like, if you're only going to see your cardiologist every 6 months or every year, your primary care is going to be the one kind of taking those recommendations and managing them on a more regular basis. Um, so that's really the model that we're working with. And the same thing goes for the primary person managing your nutrition is going to be your dietitian. And your primary person managing your mental health is probably going to be your therapist, even more so than your psychiatrist. Your psychiatrist is going to be the specialist, and your primary mental health professional is probably going to be your therapist. So we need all of these facets together, um, in order to make this effective for the majority of people. And this is going to benefit the providers and it's going to benefit the patients. And something else with that, this also leads into something I was learning about this past week. I was watching a lecture from an internal medicine hospitalist just about since the 1950s and even more recently. It used to be that hospitalists would do all kinds of procedures in the hospital setting, and nowadays that's really gone away. And it again goes back to opportunity costs and division of labor. So think, if you will, like if somebody has fluid in their lungs and uh, they need a thoracentesis. So you need somebody to do a procedure to make a hole into the lung, or at least into the pleural cavity, and possibly stick in a chest tube to help that drain. So it used to be that internists or like pediatric hospitalists would do those procedures, on their own. But the problem is, how many of those procedures are you doing to stay up to date on that? Uh, and actually, this lecture was really really funny about how they described this, because it's like, okay, so let's say you want to do this procedure. Okay, so you're going to need a kit of equipment to do that thoracentesis at the bedside. But your floor doesn't have that, because rarely does anybody get that done on the floor anymore. So you can't get it from your unit. So you have to go take, what, 15-20 minutes to go to a different unit of the hospital and maybe see if they have it or don't have it. Maybe you have to go to the OR to find it. uh, that takes extra time out of your day just to do that. And then you bring up that equipment. Oh, and also you need an ultrasound machine, which your floor doesn't have, but the ICU has. So you're going to go steal the ultrasound from the ICU, which they're not really happy with, because you got, what, two ultrasound machines and they need them in the ICU, but you got to steal it to go do your thoracentesis. Okay, fine. And then you get back to the room and now you got to set up the room. You got to wake the patient up who's been napping. You have to clear all the stuff off their bedside table. You got to move their soda cans and their leftover lunch tray, and find their glasses and their hearing aids, which takes some extra time. You got to go find the nurse who is maybe on break, or maybe someone's covering for them, or maybe they went off to go find somebody to help move the patient. So that takes, what, an extra 15 to 30 minutes. And then from there, you have to set up the equipment in the room. You have to consent the patient. You have to then do the procedure, and like do the care afterwards of the procedure. And if you have an internist who doesn't really do these procedures often, how fast is that procedure going to be? It's going to be very slow, and probably not as high quality as somebody who does those procedures every day, or like at least every week, and has those reps, and has equipment there with them. So let's think about that hour of time that was spent doing the thoracentesis. What could a physician be doing in that time frame? They could be taking another admission. They could be rounding on their other patients that they already have, which are going to generate not only just more productivity for that physician who can round very efficiently and can do admissions very efficiently. It also decreases the revenue because now you're wasting time that could be like, because if you're paid on volume, you could get paid way more for that admission than for doing that procedure. It's low, like the opportunity cost is high. And it's the same thing here when we're talking about nutrition. Like if you have a primary care physician that's like, if you've got a type 2 diabetic who has a brand new diagnosis, they're going to need a lot of time talking about their nutritional needs. Does a primary care physician really have the time or even expertise to walk somebody through 30 minutes to an hour long visit just about their nutrition? I would argue that is a poor use of their time because they could be seeing in a half hour, they could be seeing at least 2 other patients, if not 3, depending on the acuity. And they're also not, they don't get the reps in that. They're also not as qualified in that. And even with 40 extra hours of nutrition education, they're not going to be as good as a dietitian or as a nurse educator. So why we sacrifice that extra revenue? And I thought we were capitalists here. I thought we were capitalists trying to make money. So if we're trying to make money, why are we using that high expense resource for a task that they're not even well equipped to do? And it's going to take them longer and they're going to do worse at it. So I don't know. It doesn't make sense to me. But back to the procedure thing, right? So the alternative there is you let that hospitalist do the admissions, like, and they either consult interventional radiology, who, I mean, yeah, IR is expensive, and IR doesn't want to do the simple procedures a lot because they get so overwhelmed with volume. But interventional radiology is an efficiency based system on those procedures. And they got better imaging. They've got the ultrasound machine right there. They've got CT. They got MRI. They got whatever they need. They also have the ability to bring the patient in, do the procedure, and get them out right away and get them back to the floor. They have the equipment right there, the supplies right there. They've got physicians with the volume that can do the procedure very well and very easily. So if you got one or the other, you know, between those two, I probably want to be seen by the interventional radiologist. But there's actually even a happy medium between these two options. And this is also a great example of where physicians don't even need to be the ones doing this. So procedure teams, especially at big tertiary medical centers and like university hospitals, they have procedure like dedicated hospital teams for proceduralists. And so it might be they might be internists who just really like procedures and want to maintain that volume of procedures and want to be dedicated to doing that thoracentesis at the bedside. Or something else that I've seen happen more recently is PAs. PAs oftentimes in their education do really well with procedures. And I think that's one of the really, really good ways to utilize and also to utilize NPs. I've seen more as far as procedure teams. I've seen more PAs because a lot of them go into surgical specialties as first assists. Like I think one of the biggest draws to PA programs is people who want to be proceduralists but don't want to be a surgeon necessarily, want to be part of the team, um, and then don't want to risk going into applying for residency and not getting the specialty that they want, and also the ability to change positions without having to do another residency program. So PAs can get really, really good at a lot of these procedures, and also nurses with IV based procedures like central lines and that stuff. Like they like if you're doing IVs, there's this joke that like people want their physician to do their IVs for them, and unless that physician was a paramedic or was a nurse or is an anesthesiologist or interventional radiologist or something that does IVs frequently, then you don't want your physician doing your IV. Like, it's plain and simple. You want the nurse to do it. Um, but there's some nurses that end up getting their NP and then they become proceduralists. And so we had a guy um, at my hospital that I did internship at who he was really good at getting the IVs that nobody could get. And so if you had a problem, you call him and he'd come in and do it. And he'd have the equipment, he'd have the knowledge to make sure that procedure was appropriate for that person, and he'd give you feedback on, hey, I don't think this is safe for this person. And it's great team-based effort, and great learning because you know nurses are people I would love to learn more about IVs from. Um, and PAs on procedure teams can be a really good asset as far as that goes. So team dynamics, that's the core of this. And I think when we rely on this team, it's going to improve patient outcomes. It's going to reduce burnout, and it's just going to be better in the long run. And so they get into kind of a few questions here with what will be the roles and responsibilities of each team member. Clearly delineating those is going to be very important for communication and for really developing that particular skill set. Uh, Talking about conflict management, talking about how the team improves over time, all that stuff is super important. Um, but yeah, and they even get into ways that medical assistants can help kind of move things along as well, like being able to screen the patients ahead of time, like go through the charts and say, okay, do these people have the recommended screenings ordered? Like that's something that I do think medical assistants, if they're going to be doing that, should be uh, I mean, any of these teams should be doing it, discussing with each other. But I do think medical assistants should be asking, should be should let the physician know and say, "Hey, I noticed this person is not does not have hasn't had a mammogram in the last year. Should I order it for them, or like what would you like me to help with on that?" Um, and like you can train them to spot a lot of those things, and you can say, "Hey, yeah, no, this person has an indication for it. Good job." Or you can say, I don't think this is appropriate. Here's why. And that was kind of the dynamic I had with the medics in the army. Um, the medics like did a lot of that front work of saying, yeah, these people are due for these vaccines or they're due for these screenings. Um, and so that's a really good way to utilize them. Utilizing nurses there as well, utilizing pharmacists, which, oh my goodness, this is another like really, really good point. In the hospital, at least my last hospital, I'm hoping this is the case at this new hospital, is that vancomycin dosing. Vancomycin is a pretty broad spectrum antibiotic, but we use it to uh, treat MRSA. So it's one of those you start with it because like if you can't rule out MRSA, you have to assume that MRSA might be involved. You start vancomycin, but it has to be dosed very, very weirdly. Like you have to get labs and measure like how much vancomycin do they have, what is like their it's specifically measuring their trough. So how much do they uh kind of have at a baseline in their system, like based on how many days they've been on vancomycin, because you definitely don't want to overdo it. Um, and pharmacists have started managing that, and it's amazing. It's amazing because a physician who already doesn't know a lot about, I mean, some things about medications, but not to the level of a pharmacist, and especially hospital pharmacists are oftentimes residency trained pharmacists and are incredibly brilliant people, and they'll say, yeah, no, that this person, like we need to adjust the vanc dose, and they will actually adjust it on their own, and it's fantastic. Same thing with like consulting them about antibiotics in general, like what is an appropriate agent to use, asking them about sedation. Like pharmacists are uh, incredible assets for appropriately sedating people. And also clinical pharmacists are often operating in outpatient settings. So like let's talk about this management of chronic disease. There are dedicated pharmacists for diabetes, which just think about the weight lifted off of primary care shoulders if you have a clinical pharmacist that you can send someone to manage their insulin for them, or like teach them how to use their GLP-1 medication. That's incredible. Same thing, like my last hospital also had a heart failure pharmacist who managed their diuretics and who managed their other medications. And it is such a powerful thing that like people who don't work in healthcare have no idea the power of a good team and good specialists in a variety of fields. And something else like occupational therapy. My God, like the things that they do are incredible. Speech therapy and like helping people learn to swallow is incredible. And like the people, like the med student listed earlier in this video and RFK Jr. and those people like who have the arrogance to say that doctors can do all these things. No, no, we absolutely cannot. And we shouldn't. We should not let our egos take over proper care of patients. And they get into this in the article that there's this mindset, and physicians are often trained in residency to, in order to get things done, you have to do it yourself. That you can't trust other people because they're not going to do it as well as you, or that in order to get all this done, you have to stay up late. You can't go home. You have to be on call 24 to 48 hours. Like, why? Why do we have this expectation that physicians have to be something other than human? And why do we have to think that about ourselves? Like this ego is out of control. And this idea here mentioning that no one will care as much about this patient and go the extra mile is absolutely main character syndrome and is insulting insulting for every other healthcare professional that's putting in equal if not more effort on certain things. Like it's so competitive to get into these other fields too. Like being a doctor isn't the only hard job in the world. It's not the only gratifying job in the world. And it's not and you're not the smartest person in the world because you went to medical school. Like that idea needs to stop. And that's part of why people don't trust doctors. And that's a good reason not to trust a doctor. And so they mention that physicians may fear losing the sense of personal pride for single-handedly achieving life-saving outcomes for the patients. The idea of saying, "I saved his life," or "I feel good about how I handled that problem." Will we find it as personally rewarding when a panel manager facilitates the early diagnosis of colon cancer and saves a patient's life? We need to change how we view ourselves and how we view the teams that we work in. Instead of saying, "I need to do all these things. I'm the best. I can counsel you on nutrition. I can learn all this in medical school. I can do all of it in 4 years and not need a residency to teach me this." We can say, "We did this. Our team helped this person." And think about ourselves as, I'm not the main character in that person's life. Like people do not go around thinking that their doctor is the best person who's ever lived and that they're the most important thing. People don't go to the doctor to give the doctor a sense of fulfillment. Right? Individual people are the main characters in their own lives. And uh I something that I liked about going into medicine was the idea of I'm a support role in this person's day-to-day life. And being able to, like, yes, you are helping them, but it's them. It is their story. It is their health condition. It is, like, a lot of times their effort in doing all these things under the recommendations. And I'm not saying that doctors don't work for these things, they do. But we're doing it, you should not be doing it for your own satisfaction. You should be doing it for, I guess, for the satisfaction of helping somebody else. And me being the main character of that is just a dumb goal to have. Why can't I be equally happy to say, I helped in this way? I helped with this part, and you helped with that part. And I think that we're more able to be happy for each other when we're happy with the things that we're doing, and when we can appreciate the little things that we're doing and appreciate the little things other people are doing. And then patients get the best care, and I think there's no substitute for that mentality. Yeah, and the statement here that physicians should not use other team members' participation as a means to unload undesirable tasks. That's what medical students are for. Just kidding. But that's kind of the joke. But yeah, I know this seems like we took a big tangent, but that's the core of this whole healthcare nutrition expectation, right? The adding nutrition education in itself isn't a bad thing, but the mentality that physicians are good enough and should be good enough to do all of it is problematic. And that overvalues physicians, and it overburdens physicians, and it devalues and insults the experts who spend years and even decades of their lives to become amazing dietitians or amazing nurse educators or amazing therapists. And so then with all this, uh, the things that we need to change in our system, if we really, like, let's say we really, really want to improve nutrition in this country, I stand by my key factors that I think are actually going to achieve that, and that is universal health care. That is a huge one. Systemic issues with like food deserts, systemic disparities in, health issues among different zip codes, addressing social determinants of health, addressing socioeconomic disparity, valuing team members, valuing team-based healthcare, I think are going to do far more for this issue than adding 20 extra hours of nutrition education for medical students who aren't even going to remember that stuff anyway down the road. I saw we had a question earlier on in the side chat from Aunt Jer, and I apologize that I missed it back then. It was related to the vitamin B12 conversation, and whether or not it you can get neuropathy in large muscle groups, and I think it's possible. I think it's usually it's peripheral, starting from like the feet and the hands and kind of working its way up. Um, but I could be incorrect on that. Yeah, yeah, Godless Granny's point here. What, doctors are one step down from gods? Yeah, and any doctor who views himself in that way, I don't think deserves to be a doctor. And that's honestly like Dr. Oz's kind of approach to life, and I don't think he deserves to be a doctor. So that's kind of where we're gonna leave it for today. We actually have our trivia question that I need to share. I'm going to go to this view. All right. So today's trivia question was according to some of the more experimental. Oh, no, that wasn't it. Sorry. That was a couple weeks ago. Oops. I have a bunch of these saved up. No, where am I going? Image file. Here we go. Okay. A core goal of the 40-hour MD nutrition mandate is to better address the metabolic syndrome epidemic. However, when a patient consumes an excessive amount of refined carbohydrates, the body performs de novo lipogenesis to convert that glucose into fat. In humans, what is the primary anatomical site where this biochemical reaction occurs, and how does it differ from most other mammals like rodents? Which that's kind of that second part is just a for thought question for you all. But the answer is the liver. Hepatocytes are the primary producer of fat cells and cholesterol in the human body. So the more you know. And if you show up to trivia, this may be a question in the next round of trivia. All right. That is enough. We are a little bit over time. Thank you, everybody, for joining me in this episode. Please hit that like button, subscribe to the channel. There's also my Twitch link in the side chat if you want to follow over there. Please share out this video, put comments in the comment section. All of that helps me out. And I do plan on streaming next week. I have yet to decide my topic, but once I know, I'll post the link for that. And I will see you all next time. Bye, everyone.